Welcome to CRT 2020. I'm Ziad Ghazal from the American University of Beirut. We're privileged to have with us today Dr. Donald Cutlip from the BAME Institute. Our topic today is going to be on a drug-coated balloon with Sirolimus elution. So Don, to begin with, the existing drug-coated balloon in the international market have been with Paclitaxel as the eluting drug. Why hasn't Sirolimus, what were the challenges with using a drug-coated balloon with Sirolimus rather than Paclitaxel?
Sure. Well, first of all, I should say that we have lots of data from drug-eluting stents where Sirolimus is probably a preferred choice for preventing and treating in-stent restenosis. But Paclitaxel is much easier to deliver. So it's lipophilic, it can be just delivered to the vessel, pretty quickly taken up by the wall and deposited there where it may stay for a long while. So very effective, but some concerns about toxicity. The problem with Sirolimus is that stage of getting it to the vessel wall and having it be delivered long enough to be taken up by the wall. So it's required developing some excipients where the drug can be delivered, stay around long enough near the wall, and then be absorbed into the wall where it can be effective. So some companies have gotten to a point where we're close to having that happen, and we're starting to design trials now for that space.
Okay, so before we go on designing a trial, I'm curious, why is it that in the United States, drug-coated balloon, the Paclitaxel drug-coated balloon that has been so widely used internationally, why hasn't it made it to the US market?
That's a great question. And I don't have the answer except to say I suspect that the regulatory process is fairly involved. I know what we're seeing for Sirolimus is fairly involved, and I suspect it would not have been much easier for Paclitaxel.
Right.
So the number of patients, the follow-up, the angiographic follow-up, and so forth are a bit onerous, but it shouldn't have taken this long.
Right.
I mean, it's been in Europe for I don't know how many years, but
right.
long
It's been in Europe for many years,
yeah.
and of course beyond Europe in the world. So now you want to design a trial using a drug-coated balloon with Sirolimus and compare it to, let's say, drug-eluting stents, to POBA, to in-stent restenosis treatment. How would you, what would you keep in mind when you design such studies?
Yeah, well, I think you touched on it. The most important question is, what should the control group be? Since we want to use this as a way of getting drug-eluting balloons into the US, we have to do a randomized trial, and it can't be randomized to a Paclitaxel balloon because we don't have it, as you already pointed out. So the two choices for control are DES or POBA. If we look at our national registry data, in-stent restenosis, which is probably the targeted population to try to get approval for first, about 80% of those patients are treated with a repeat drug-eluting stent, and about 20% are treated with POBA. POBA is probably reserved for those with multiple restenoses where we don't want to put another stent, or very simple lesions. So which of those controls should we use? The problem with DES is that there are going to be patients we don't want to put another DES, so we have to restrict the population to probably 0 or 1 prior restenosis. And then there are problems with second DES even in that first patient, even in that first treatment, as far as DAP duration, thrombosis, changing the flexibility of the vessel, vasomotor function of the vessel. So there are a lot of interventionists who think we should not be restenting.
Right.
So then you're left with a POBA control. The problem there is that we have lots of data showing that POBA just is not very effective.
Absolutely.
For preventing a second restenosis. I mean, the differences are 30% and higher for POBA, and 8 to 10% recurrent restenosis for DES. So I would certainly argue that POBA is not a good standard of care. And what we've come up with is actually a way of trying to include both types of patients with sort of a hybrid control.
Right, and I agree with you. The POBA, just learning from the drug-coated balloon randomized trials that have been performed, the Paclitaxel one, I mean, POBA is probably not something we should if I may say, waste time, using it as a control arm, because we know most likely where that's going to go. And on the other hand, in terms of drug-eluting stents, you don't want to create this onion ring effect of several layers of stents. So that would be very interesting.
Yes, I agree.
So take me to the Med Alliance. What kind of project do they have there in terms of drug-coated balloon, the solution, if you want to talk to me a bit about
Certainly,
that?
Sure. Yeah, so Med Alliance is one of at least 4 manufacturers who wants to enter the US with a Sirolimus eluting balloon. They all have slightly different methods to get the Sirolimus to the vessel wall, so in the interest of time, I'll just talk about the Med Alliance. They have a proprietary membrane, what they call a cellular adherence technology, which traps the Sirolimus, which is in little bioabsorbable polymer particles, against the vessel wall with a balloon inflation, where it lasts long enough to be absorbed. And then the data show that the drug is effective in the tissue for at least 60 days,
right,
which is about the time of ideal for preventing restenosis. In terms of the study design, what we've presented is a hybrid control, where most patients would probably get a DES, but we reserve patients can get a POBA. Because of sample size determination and so forth, we have to cap that POBA rate at about 20%, which does match what we're seeing, at least in the US, for POBA use. And then we're doing a non-inferiority design. And because DES is so effective against POBA, the non-inferiority margin can be fairly large, because we only have to show that we're at least as good as drug-eluting stent versus placebo.
Right.
And so that's the design. It'll be about 380 patients randomized. Very importantly, the randomization takes place after an effective predilation. So patients can't be randomized until you've prepared the lesion adequately, because we know that's very important for success in these patients.
One last question. So in your current practice, Don, you have one single stent restenosis. What do you do?
What do we do now?
What do you do now in your practice? And the other question is, if you already have 2 stents in there, what do you do?
Yeah. If we only have 1 stent in there, we would almost always place another stent. If it's a focal restenosis, we might try to get an optimal result with balloon. If we got a perfect result, we might leave it. But I would say over 90% of the time we would place another stent. If they already have 2 layers, we would try not to place another stent. We would try to get a good result with POBA. But if we couldn't, we'd have no other choice. We'd have to place.
And we know with POBA, with already 2 stents in there, we're looking at a significant,
probably 40 to 50%
recurrence rate. So,
absolutely.
I hope the new generation, if I may call it, drug-coated balloon with Sirolimus, prove themselves. And because it's badly needed in this market, that we have something new to offer to the patient who have in-stent restenosis.
Yes. Well, I think for US patients at least, we're going to see trials starting sometime in the next year or so.
Very good.
We'll get there.
Very good. Thank you so much, Don. That was terrific.
Thank you. Thanks.